the lung cancer session with Professor Filippo De Marinis. Thank you very much.
Many thanks, Giuseppe, for your kind presentation. Many thanks also Roberto Recchia for his presentation and for this opportunity that for the third year is IEO obtained from Asco to be the representative of the best of Asco in Italy. I think that this is an important opportunity that we catch very enthusiastically. So our session is divided into groups of abstract selected and reported by Gianluca Spitaleri about the target therapies in non-small cell lung cancer and Antonio Passaro regarding the immunoagents in non-small cell lung cancer. We have the honor to have Fabrice Barlesi to as a discussant, as a rapporteur of this presentation. Fabrice Barlesi is a key opinion leader in lung cancer tumors and the general director of Gustave Roussy Hospital in Paris. So we are very excited for his participation to this meeting, and in some minutes he will be with us in our room. We'll have the time for some question and answer, and all our presentation will be in the next hour. So I invite Gianluca Spitaleri to start his presentation, presenting a selection of abstracts presented at the Asco meeting about the target therapies in non-small cell lung cancer. Please, Gianluca.
Hello, good afternoon. Dear colleagues, thanks to Professor De Marinis and Professor Curigliano for the kind invitation, and thanks to Professor Barlesi for honoring us by discussing our presentations. I have selected three abstracts related to three main topics in non-small cell lung cancer harboring molecular driving. The first one is about EGFR positive non-small cell lung cancer, and in particular, how to overcome osimertinib resistance. The abstract is abstract 9006, presented by Dr. Xu, and it's about the updated results from CHRYSALIS-2, the combination of amivantamab and lazertinib in patients with EGFR positive non-small cell lung cancer after progression on osimertinib and platinum-based chemotherapy. Osimertinib, according to the international guidelines, is the preferred option for the first-line treatment of stage 4 EGFR positive non-small cell lung cancer, thanks to its best median progression-free survival, the first drug to attain an overall survival gain, and its dramatic control of brain disease. However, most, if not all, of the patients progressed on osimertinib. If there is a systemic progression, we can choose for the patient or a standard way that is represented by platinum-based chemotherapy, or a clinical trial that we can didactically distinguish in unselected or selected for biomarker of resistance. For many years, the clinical research is focused against the principal mechanism of resistance to osimertinib, represented by MET amplification, and the on-target mechanism. It has secondary EGFR mutations that confers resistance to osimertinib. The combo is constituted by amivantamab, that is a bispecific fully human antibody that acts via three principal mechanisms: inhibition of EGFR and MET, receptor degradation, and immunomediated phagocytosis, also known as cellular knowing. Lazertinib is a novel EGFR TKI of third generation that acts against a broad spectrum of EGFR mutations and as a broad brain penetrant property, and as a broader therapeutic index with respect to osimertinib, thanks to less rash, less diarrhea, and less effect on QTc prolongation. This slide depicts the Cohort A study design of CHRYSALIS-2. Patients must have received osimertinib and platinum-based chemotherapy as last line. The patients were split into two groups, target population up to 3-4 lines, and evenly pretreated patients where there were no restrictions to number of prior lines. Overall response rate was the primary endpoint. What to do we already know. From Chrysalis study, we have learned that the combo AMI plus LADS is superior to AMI alone in terms of response rate and duration of response, and that this activity is respective if we identified EGFR MET-based resistance or not. So far, the authors decided to go on in an unselected way with CHRYSALIS-2. The preliminary results of this trial were presented last year at ESMO Congress. With a follow-up less than 5 months, they demonstrated that the combination AMI plus LADS is active against target population and evenly pretreated patients. So what's new at this Asco? The authors presented the results from fully enrolled cohort and with a more mature follow-up at 10 months. The patients were 162. The median number of prior therapy lines was 3. Around 41% had brain metastasis at enrollment, and 2/3 of them received osimertinib as first line or second line and then chemotherapy. In my opinion, this is the key figure of this work, represented the overall response rate of amivantamab and lazertinib. It is 33%, distributed according to the prior lines of treatment. And we can see that the combination was active irrespective of prior lines, with ranging from 21% to 39%. Amivantamab and lazertinib led to durable disease control. Both stable disease and responses were durable. And of note, among 27 patients with untreated brain metastasis, they recorded 7 complete responses. Regarding safety, most of the adverse events were grade 1-2. Grade 3 pneumonitis was 4, and no new safety has been identified. So the authors concluded that chemotherapy does not impact amivantamab and lazertinib activity. The CHRYSALIS-2 study is ongoing, and the combination will be studied in 2 larger phase 3 randomized trials that are Mariposa and Mariposa 2. Mariposa is an upfront setting, will be compared to the combination with osimertinib, and Mariposa 2 is after osimertinib progression, and the combination this time will be added to the chemotherapy. To check out the preliminary results of other combination, I selected 2 other abstracts of clinical trials with Teliso-V, and we can see that when Teliso-V is added to a third generation, this time is osimertinib, the percentage of overall response rate improves from 17% to 58%. In this case, in these studies, the population was selected for c-MET overexpression. Mezitumumab plus osimertinib instead gave only a modest impact with an overall response rate of 16%. Moving to the second topic, MET exon 14 skipping mutation, I've selected abstract 9008 presented by Dr. Krebs from Chrysalis study, was dedicated to the cohort of patients with exon 14 skipping mutation. After several years, we have learned which is the real driver among the other MET dysregulation. It is the MET exon 14 skipping mutation. The prevalence in European lung cancer patients is around 2.3%. We have already two drugs, two small molecule TKIs for this disease, capmatinib and tepotinib, that attained the FDA and EMA approval. But in Italy, outside the clinical trials or expanded access program, we don't have access to these drugs. This slide depicts the cohort MET exon 14 population Chrysalis 1 study design. The objective principal endpoints were safety and efficacy. In total, the patients were 55. They were split in three groups: treatment naive 9 patients, no prior MET inhibitor 18 patients, and 28 patients that were pretreated with MET inhibitors. The overall response rate was overall 33%. Importantly, the activity in the treatment naive group and the patients pretreated but not with MET inhibitor were 57% and 47% respectively. Instead, the activity in the prior MET inhibitor group was modest, only 17%. This is the key figure, in my opinion, for this work. Amivantamab led to durable response, both for stable disease and responses above all, and the median duration of response is not reached. Regarding the safety profile, no new safety signals were found. And regarding my conclusion for this work, encouraging results for the high response rate in naive and no prior MET inhibitor group, and above all, long durable responses. The bad news is the low responses rates in MET inhibitor group. The choice between amivantamab or small molecular TKIs, please wait for Professor Barlesi. Moving to the last but not the least topic is the KRAS G12C inhibition. KRAS amounts around 30% of all non-small cell lung cancer. G12C is around 40% among all the KRAS mutations. And as for EGFR positive lung cancer, also patients with KRAS positive non-small cell lung cancer are a high risk to develop brain metastasis at diagnosis. The treatment algorithm for KRAS G12C in Italy is represented in the first line by immunotherapy alone or in combination with chemotherapy according to the PD-L1 expression, and the second line sotorasib. The abstract 9002 presented by Dr. Spira was about Crystal-1 activity and safety of adagrasib. Adagrasib is a covalent inhibitor of KRAS G12C with CNS penetration. This slide depicts the study design. Besides KRAS G12C mutation, patients must have received prior treatment with immunocheckpoint in combination or in sequence with chemotherapy. Treated stable CNS metastases were allowed. They enrolled 116 patients. The primary endpoint was the overall response rate. The patients were 160, almost all were ever smoker, almost all received immunocheckpoint chemotherapy, and around 21% of them had CNS metastasis at enrollment. The overall response rate was 43%. The median response was 8.5 months, and the median progression-free survival was 6.5 months. On the right, you can see that the overall response rate was irrespective of PD-L1 expression. Instead, on the left, we can see that only KEAP1 mutation seems to jeopardize the activity of adagrasib. Sabari et al. Focused on activity of adagrasib against untreated brain metastases. There were 25 patients, but 15 patients with target lesions. The intracranial over response was 32%, with an intracranial duration of response that was not reached. So big assets, great results with such difficult disease, but with two important liabilities. The first one is toxicity. The grade 3-4 rate toxicity was 43%. Main frequent toxicity, diarrhea, nausea, vomiting, fatigue can jeopardize the quality of life of patients. And there were advantages that lead to dose reduction and dose interruption in 52 and 61% of patients. The second liability is that the drug can interfere with most common drugs. And I'm not kidding you when I say that even loperamide, that is the common drug that is used to manage diarrhea, cannot be used on study. And diarrhea is the most frequent adverse event of adagrasib. So far, my conclusion for the first abstract seems from the several trials that the patients need to continue or start a third generation TKI in addition to the new drug. For the first and the second topic, amivantamab seems a double-decker drug, a drug fluid with targeted and immunomediated activities. And regarding adagrasib, excellent results with such a difficult disease, but at the cost of high toxicity. Thank you and enjoy your Asco.
Okay, Gianluca, thank you so much for your presentation. I take advantage to give my regards to Fabrice Barlesi that is online with us. Thank you, Fabrice. Thank you for your coming. I presented you before, but I will present you another time after the next presentation by Antonio Passaro. And his topic is about the immunoagents in non-small cell lung cancer. Please, Antonio.
Thank you for the introduction, and thank you for the organizing committee for having me today here. So my talk will be to the presentation that will focus on the immunoagent presented during the Asco. And this was a transition year consisting on the discussing a new agent about the immune checkpoint inhibitor for patients with the resistant disease, also with a naive disease. Here, my disclosure. This was my selected abstract, and as you can see, the first two abstracts was a two FDA pooled analysis. Both of these two abstracts focus on the need of clinical practices to improve and prioritize patients according to PD-L1 or some predictive biomarker, considering that in clinical practice, we're not allowed to use the combination of chemo plus IO for patients with a PD-L1 more than 50%. In this first evaluation, the colleagues working in the FDA evaluated all patients that received the combination chemo-IO and IO only for patients with more than 50% of PD-1 expression. This is a very clinical need to understand the real power of the combination in our clinical setting. And this is a very clear summarizing table. We can see that no significant difference improve the rate of response or survival for patients that receive chemo-IO compared to IO alone. But if we read deeply this number, we can see that a clear benefit will jump out from patients that receive the combination. So this is clearly that focus on the need that sometimes in clinical practice we need to improve the efficacy endpoint, and that the use of immune checkpoint alone is not the best strategy. Consider also the rate of progression disease in the first 3 months. The authors concluded that this kind of pooled analysis does not suggest a significant difference for patients considering the overall survival in favor of the combination compared to immune checkpoint inhibitors alone. But of course, some difference was identified, and this will be interpreted according to the context of the clinical setting. I'm sure that Professor Bavlesi will perhaps to understand these results. And of course, in my opinion, the key point of the age is important to understand this kind of combination or monotherapy. And here, the combination of chemo-IO should be not performing very well compared to the IO alone, including also the safety analysis. The second abstract that was reported by the FDA colleagues was to identify the impact of the KRAS mutation for patients that receive immune checkpoint inhibitor in first-line setting. We know that, as I just discussed by Gianluca before, this is a very important topic also for clinical practice, considering that we are able to use the KRAS inhibitors only for patients with a pretreated disease. And the background slide that was reported during the Asco confirmed that to date, about 13% of patients with a non-small cell lung cancer show with a targetable KRAS mutation, and about 30% of patients overall show a KRAS alteration that to date are not candidates for target agents. And it's important to understand that the impact of the KRAS mutation or KRAS wild-type disease is a clear effect in the survival of this kind of patient when treated with immune checkpoint inhibitor alone or with immune checkpoint inhibitor combination. The investigators evaluate, as discussed before, the impact of this kind of treatment alone or in combination, considering the difference in overall response rate and in overall survival. As you can see here, we can see that the patient with the KRAS mutation benefits so far for the combination chemo plus immune checkpoint inhibitors alone, confirm the need to prioritize in this kind of patient when feasible the combination. And for patient candidate for immune checkpoint inhibitor alone, regarding the high PD-L1 expression, there are not significant difference. And of course, the combination perform better than the immuno alone. The conclusion of this very simple but is important topic was that the patient with a KRAS mutation, non-small cell lung cancer, benefit from the combination on immune checkpoint inhibitor plus chemo, similar to those with the KRAS wild-type disease. And all patients benefit or appear to benefit to adding the chemo to the immuno alone. So this was a very simple abstract and presentation, but that give us more information for the management this kind of patient in clinical setting that now are candidates for specific compound only in pretreated setting. Moving forward in this transition here for immune checkpoint inhibitor here, we have a different kind of presentation that try to improve the efficacy endpoint for patients with a not pretreated disease and for patients with a naive. Here we have the presentation by Enriqueta Felipe that reported the preliminary data of an investigational agent, anti-LAG3, anti-LAG mode alpha, combined to pembrolizumab in patients with the naive disease, regardless the PD-L1 expression. This was the study design, and in the green, we can see that this was all the part that was presented after. We have a number of more than 100 patients that was a candidate to receive a combination anti-LAG3 plus pembrolizumab. The safety profile was quite consistent with this data that we are just able to identify in patients that are candidates for immune checkpoint inhibitor alone. But we can see that about 12% of patients developed dyspnea during the treatment. And of course, this kind of toxicity for patients with lung cancer is, of course, a key point for future evaluation. The waterfall plot for the overall response rate confirmed that the response was quite interesting, but more pronounced for patients with PD-L1 positive, and in particular for patients with more than 50% of PD-L1 confirmed that we need maybe some additional target and some additional biomarker to identify the combination for patients with the naive, also balancing this with the safety profile. And the conclusion slide by Enriqueta Felipe, they confirmed that the overall response rate was encouraging for patients regardless of the PD-L1, but of course, this kind of data was more pronounced for patients with PD-L1 more than 50%. And this kind of combination is at the present time under investigation in future trial to identify the best cohort and setting for this kind of combination. In the presentation by Karen Redkamp, the investigator reported the conclusive results published contextually on the JCO for patients with a resistant disease to immune checkpoint inhibitors alone that was a candidate to receive ramucirumab plus pembrolizumab compared to the standard of care in this particular setting, that is docetaxel or docetaxel ramucirumab. This was a well-designed trial with about 130 patients that was enrolled regardless of the PD-L1 or the PD-1 in first-line therapy, with the primary endpoint of the overall survival. And the overall survival was met with an improvement about 3 months for patients that candidate for the combination of the ramucirumab plus pembrolizumab compared to the standard of care of the chemo alone or chemo plus ramucirumab. And this is very clear benefit from the beginning of the curves to the tail of the curves. In my opinion, this was a little bit interesting to understand that also the progression-free survival, as for the old trial that evaluated the immune checkpoint inhibitor alone, did not match the improvement for this kind of patients. And also we can see that all the subgroups analysis tend to favor the combination, but I think that in the resistance setting disease, the need to improve the PFS is important. And of course, this is a positive trial, but the results should be balanced and consider the safety profile that, of course, is a little bit pronounced for particularly safety profile as a vascular disease using a ramucirumab, but globally the results are interesting, consider the safety profile. The authors concluded that the combination in patients that was previously treated with immune checkpoint inhibitors and platinum chemo was good, improving the overall survival, but there was a clear discordance considering the overall response rate and the progression-free survival. Of course, this kind of combination, in my opinion, should be deeply evaluated also in phase 3 clinical trial and not stopping here during the phase 2 evaluation. The other trial that evaluated a combination patient with a resistant disease to immune checkpoint inhibitors was an interesting combination of cabozantinib plus atezolizumab compared to cabozantinib alone in patients treated with a pretreated disease that was presented by Joe Neal. The study design was a clear and very well developed with 80 people in the combination arm and 30 people in the alone cabo treatment. And the results was quite good, confirming that, of course, this kind of combination suggests a potential activity, but the progression-free survival, in my opinion, was limited, considering the setting with a 0.5 months of median in this kind of disease, with a median overall survival that changed according to the PD-L1 expression for patient candidate to the combination. The conclusion for the author was that the combination of cabo plus atezolizumab, of course, showed encouraging clinical activity more the cabo alone, and the response was observed with cabo plus atezo regardless of the PD-L1 expression. Toxicity with the combination cabo plus atezo was consistent with the previous report, in particular for renal cell carcinoma, which the cabo showed a very important development here. And for our last presentation, in my discussion, I selected the Skyscraper 2 trial. That was a trial for the small cell lung cancer disease. This was candidate patient to receive a chemo plus immunotherapy with or without an anti-TIGIT, tiragolumab. This was a very well-designed trial with about 500 patients enrolled. that was evaluated to receive the combo compared to the standard that chemo plus immune checkpoint inhibitors with a different kind of endpoint, but the primary point was overall survival with the progression-free survival. So there is the evaluation and the results for progression-free survival was clear negative in favor of the combination. And we have a 5.4 compared to 5.6 for both the arms. And these results was also confirmed from the overall survival analysis, confirmed a not significant improvement for the combination, a very, very equal survival benefit. This was only confirmed for the over objective response rate that was similar according to arm of treatment. And the conclusion of Charles Giroudin, the discussion was that of course, there is no difference in favor of PFS or OS for patient that was a candidate for the investigation arm. And this is the second important trial that failed in a different disease. The first was in non-small cell lung cancer, the use of tiragolumab in patients with a resistant disease. The investigator concluded that future OS analysis and biomarker will be ready to improve our understanding. But of course, this is a big backbone to identify that here we need maybe some biomarker to improve the survival of this kind of patient population. Thank you very much for your attention.
Okay, thank you, Antonio, for your very large presentation. So is the time of our guest. We invited Fabrice Barlesi, a very important key opinion leader worldwide in lung cancer, and now General Director of Gustave Roussy Hospital in Paris. So I'm very happy, Fabrice, that you have find some time of your time to participate to our session in the best in Italian best of Asco. I offer you. We have all time that we need, that you need. You have near half hour to discuss all the abstract presented. So take your time for the best presentation. Please, Fabrice, thank you.
Thank you, Filippo, and thanks for the invitation to participate in this Best of Asco from Italy. It's a great pleasure to share this session with you, Gianluca, Antonio, and all the attendees. And as Gianluca already said, it was not a big ASCO regarding all the changes, but I think we still have some very interesting information, and I will try to discuss some of the studies that have been already shown by Gianluca and Antonio. Then here are my disclosures. Then, first, where do we stand regarding immuno-oncology right now? And I believe that our issues right now is about resistances. If we look at the activities of PD-1 or PD-L1 inhibitors, I just took the example of the studies with pembrolizumab, but it's also true for all of the other studies. In fact, what it is in the second line setting or in the first line setting, we have at least 30 to 50% of our patients who are primary resistors to immunotherapy, with what means people progressing before the 6 months of treatment. And we know that if we look at the other drugs, it's quite the same. The problem is, how can we understand that and what explains that? And it's true, even if we look at patients with more than 50% of PD-L1 expression, as we will see. Then the first point is one of the part of the resistances may be explained by the absence of antigenic proteins. And we know that it may be related to the low mutational burden, the lack of neoantigens, the loss of antigen expression, and whatever. And we know that to overcome this absence of antigenic proteins, the addition of radiotherapy or the addition of chemotherapy may help to sensitize the tumors to the immune checkpoint inhibitors. The second point is, how confident can we be regarding the PD-L1 expression, because of course it may influence the results of the activity of these drugs in a group that is called PD-L1 high expressor. The results show that we already have an inter-observer variability in more than 10% of the cases when we try to to qualify the patients for PD-L1 expression of more than 50%. And we know that we also have a spatial heterogeneity, and that may lead to 33% of false results regarding the PD-L1 expression. It's correlated with the biopsy size. That is important when we talk about stage 4 advanced non-small cell lung cancer, where the diagnosis is almost always done with bronchoscopy or transthoracic biopsies. And we know that the sensitivity for characterizing the PD-L1 expression when doing just one core biopsy is only 77%. And if we are not facing a patient with a true PD-L1 of more than 50% expression, then we know that chemo-IO is clearly better than IO alone. It was at least suggested, I would say, in this study reported 1 year ago in this subgroup of patients between 1 and 49% of PD-L1 expression. Then if we are a little bit less, that may be the case if we are not able to very nicely characterize patients with more than 50%. Even if we are not in this case, what is the interest if we look at the results of the chemo-IO and the results of IO alone regarding the response rate and the duration of response? And we have the results with the pembro alone. If we look at the Keynote 189, if we look at the Keynote 24, the response rate, even if it's cross-trial comparison, is clearly superior for the combination of chemo-IO, especially if we look at the results of the Keynote 042. The Keynote 042 is for me, and we will discuss this point later if you want, but I believe that the Keynote 42 is clearly more realistic regarding what we can expect from the immunotherapy alone, even in the subgroup of patients with more than 50% of PD-L1 expression, compared to the Keynote 024, a study in which the patients were very highly selected because it was just the beginning of the use of immune checkpoint inhibitors alone. Then we know that having a better response rate may help to better control the symptoms of the patients, and we know that it's clearly better with chemo-IO. Then if we look now at the number, and I believe that the comparison between Keynote 42 and Keynote 189 are clearly those that may help to understand what could be better for our patients. We can see that the 12 months PFS rate is better for the combination of chemo-IO. It's also the case for the progression-free survival, and it's also the case if we look at the 12 months overall survival rate. Then, in this context, we had the results of the study proposed by the FDA analysis, which is a pool analysis population for the patient with PD-L1 of more than 50% PD-L1 expression. And we know that in this study, it was centrally assessed PD-L1 expression without any EGFR ALK sensitizing mutations, and it was the trial that supported the FDA approval. Then, if we look at the results already shown by Antonio, we can see that, of course, there is a numerical advantage for the chemo-IO that I believe is in line with the results that I already show you from the registration trial. We have a superiority regarding the PFS and the overall response rates. And if we look at the subgroup analysis, I don't know if we can really how we should interpret the influence of the age, because it's likely in all of these studies that all those patients have maybe be included more in studies with immunotherapy alone compared to studies that compare chemo and IO. Then it could be true, but I don't know if it's completely the reality in our practice. What seems for me quite important are the results that we have in the never smokers population. I don't know what is your practice, but if we look at the patient with high PD-L1 expression, we know that we have a part of those patients who are never smokers, and in these patient populations, the activity of chemo-IO is clearly better compared to the activity of IO alone. Then maybe from this analysis, what could be the summary is the fact that we know that we have patients that are not beneficiating too much from the IO alone because the tumor is progressing too rapidly compared to the patients receiving chemo IO, and the chemo helps to control the tumor. But in this setting, some of the patients, it's difficult to select the patients. We don't have the objective arguments to make these selections, maybe with the exceptions of the never smoker patients. If we look at the KRAS mutated patients, I would say that the results are quite in line. If we look at the activity of chemo and IO, the activity is clearly in favor for it's clearly better for the patients with KRAS mutations. And if we look, I would say at the column, the results are also in favor in the two populations for the combination of chemo IO compared to the immunotherapy alone. Then I believe that this population is not specifically representing main differences compared to the global populations. In addition, we can say that it's quite difficult to interpret the results of the KRAS wild type group, because in this group, we probably have, as the patients were not completely molecularly characterized regarding all of the oncogene addictions that we know. And we know that as they are mutually exclusive, probably in the group of patients with KRAS wild type tumors, there may be some patients with at least BRAF, RET, or some other alteration if we exclude patients with EGFR and ALK molecular alteration. Then, if we look at the resistances and the mechanism of resistance that we know or that we suspect, because the biology is not always confined by the clinical data that we have, we know that some of the mechanism of resistance may be linked to the other immune checkpoints inhibitors. And it's the case for TIM3 or LAG3 that are the inhibitors. And you can see on the bottom some of the other checkpoint that may be activated, and you remember the studies with OX40 that have been presented 1 or 2 years ago. Then, trying to double block immune checkpoints is of course of interest if we believe that the blockage of PD-1, PD-L1 alone is not sufficient. And it's in this with this rationale that this study looking at overcoming primary resistance by targeting other checkpoint inhibitors, and in this case, LAG3, was the rationale of this study, TACTI-002 study that was presented. Of course, if we look at the results, we have to remember that those patients receive a combination of pembrolizumab and LAG3. And if we look at the overall response rates or even the disease control rates in these different subgroups, it does not seem that the LAG3 is adding a lot compared to what we know of from this activity of the pembrolizumab alone. And in this situation, of course, it's really difficult to do cross-trial comparison. It's one specific trial, but the results are not highly exciting. If we look here, and I put it in a larger manner, you can see in PD-L1 more than 50%, the response rate is 52%, and we know that's quite close to what we can get for pembrolizumab alone. And of course, we have to remember that the number of patients treated in this trial are quite small. Then, looking at the combination with another type of checkpoint inhibitors, we know that the data with TIGIT inhibitors, tiragolumab, have been reported regarding the small cell lung cancer, and Antonio just presented this result, the Skyscraper 002. But we had a press release from Genentech that said that the phase 3 Skyscraper 01, which was a study looking at exactly the same setting that we have just seen for the LAG3 in the high 50% high PD-L1 expressor, then those patients with high PD-L1 expression, more than 50%, were randomized between this atezolizumab alone or atezolizumab plus tiragolumab. And we know that this study did not meet its co-primary endpoint of progression-free survival. Then we have some disappointing results regarding the combination of more than one checkpoint inhibitors, or at least checkpoint inhibitors outside PD-1 or PD-L1. Conversely, if we look at how we can overcome secondary resistances, we know that targeting VEGF or VEGFR makes sense. We know the role of VEGF in the inhibition of DC maturation, antigen presentations, cytotoxic T cell proliferation and infiltration. And we know that VEGF is promoting an aberrant tumor vasculatures and has also a direct immunosuppressive functions on myeloid-derived stem cells, Tregs, and tumor-associated macrophages. Then it's not surprising that we have a lot of data right now showing that the combination of CPIs with either lenvatinib, cabozantinib, ramucirumab is providing with some additional efficacy in this setting. Of course, one of the issues is that we are not able for the moment to find how to select those patients who are really benefiting the most of this combination. But I would say that regarding all of the trials that we had in the second line setting in patients with secondary resistance to checkpoint inhibitors, it's probably with the combination of VEGF or VEGFR inhibitors that the results are the most important and the most exciting. But one of the questions is, but where has precision IO medicine gone? And it's a question because if we look at all of the trials that have been presented, we do not have any trial that has been designed on the basis of a molecular characterization of the mechanism of the resistance. But there was some data presented. I just took this example, of course. It's a poster done by our colleagues of the Dana-Farber, and they show in this study where they do a sampling before treating the patients and at the time of the PD-1 or PD-L1 progression, they try to identify the type of molecular alteration that came. And you can see here it's the acquired mutations, and here it's the acquired copy number alteration. And if you look at the genes that change the alteration that were acquired at the time of the resistance, you can easily understand that these molecular alterations may clearly influence the probability of response to checkpoint inhibitors in the future. Then clearly, if we are not able to select the patients on the basis of the molecular alteration that have been acquired during the first CPI treatments, it's unlikely that the globality of the patients would respond to continue a CPI and adding some CDX. Then probably we have to be a little bit more smart in designing our trials and try to adapt our strategies to the molecular alteration that are present either at the time of the start of the treatment or at the time of the progression. If we look now at the oncogene-addicted tumors and the patients with this type of molecular alteration, we know that we have many targets. We have some inhibitors, not for all of the molecular alteration that we know, but unfortunately for the moment, we are not able to cure our patients with oncogene-addicted tumors. We are able to prolong the progression-free survival. We are able to provide them with long overall survival, and probably one of the longest with the ALK inhibitors. And we know that for the ALK rearranged patients, we have a lot of different strategies regarding the first-line treatments, many represented by alectinib right now, and the second or even third-line setting of inhibitors. It's not the case for all of the tumors, and I believe that what we should try to do is to also better understand the mechanism of resistances and how we can block it. Then the first point is to try, before looking at the resistances, to try to increase the number of targets that we are able to target with quite potent inhibitors. And as presented by Gianluca, this year at Asco, Mirati presented the updated analysis of the Crystal-1 study. The previous release was based on approximately 60 patients. Now it's 116 patients that have been presented in this analysis with adagrasib, KRAS G12C inhibitors. What is interesting, if we look at the results regarding the waterfall plot, you can see that almost all of the patients present with some changes in the tumor burden, and the response rate is 43%, very close. I will show you the data for the sotorasib just after that. The disease control rate is 80%, something that is clearly superior to what we can expect with the standard docetaxel, and you can see that more than 75% of the responders achieve a more than 50% tumor reduction. What is interesting is the length of response with the adagrasib. In this setting, you can see that the median duration of response was 8.5 months, and these results are quite immature because the treatment was ongoing in 50% of the patients who experienced a response. If we look at the other inhibitor, the sotorasib, we have the results of the phase 2, and you can see that the response rate was 37%, quite comparable, even if numerically a little bit lower. The disease control rate was exactly the same, 80%. The duration of response was a little bit longer, and the median PFS, 6.8 months. Then clearly we have now two very potent inhibitors. The safety profile of the two drugs is a little bit different. And if I can say, we participated in trials with both sotorasib and adagrasib, and I would say that the management of the patients is quite easy with these drugs. We know how to manage the side effects, even if we have to carefully look at the pharmacological interaction, as already said by Antonio. But regarding the KRAS G12C inhibitors, they have to demonstrate the superiority regarding the docetaxel, and we know that the two phase 3 trials are ongoing. We made up a release next year, maybe at Asco next year. And also, we know that these inhibitors are moving to the first-line setting. We have preliminary safety data for the combination with PD-1 or PD-L1 inhibitors, which is, of course, one of the major expectations that we have, with chemotherapy also, and with some other TKIs that block co-molecular alteration that are sometimes present with KRAS mutation. Moving now to another target, the NET exon 14 alteration. As you know, we already have some inhibitors in this setting with the crizotinib. That was one of the first NET inhibitors that we had in our hand, but also capmatinib and tepotinib, and we know that these two drugs have got FDA approval. What about the amivantamab? The activity of the drug in this study that included both treatment naive, but also already pretreated patients, and some of them priorly pretreated with the MET inhibitors. The response rate was interesting in this study. You can see that the number of patients, especially those who were treatment naive, are more likely to respond to the amivantamab. What is also very interesting is the duration of response in those patients who are responding. It's the blue lines in this spider plot, and you can see that for those patients who are treatment naive, the median PFS was not evaluable and was probably very low. If we want to discuss how to choose between these oral TKIs or the amivantamab, I would say that ideally it would be interesting to decide on the basis of co-molecular alterations that may be present along with the MET exon 14 alteration, or and have a precision-based decision. If we look at the safety profile, I just completed the table done by Antonio, but you can Antonio, you can see that if we compare the grade 3-4 adverse event, the amivantamab is doing quite the same compared to the tepotinib, a little bit better than the capmatinib. The number of patients who had to go to a reduction dosage is quite comparable, almost 1/4 of the patients. And the number of patients who had to discontinue the treatment is clearly the same, around 11%. The number of patients with ILD was around 4% in all of the trials. Then at the end, I would say that my decision will be based on how to protect the quality of life of those patients. And I believe that for the vast majority of our patients, an oral drug may be a better choice compared to an IV drug, especially if we can provide them with this possibility that we know is only for one small part of the duration of their treatment when they are getting a stage 4. If we move now to the EGFR mutated patients, you of course know that the mechanism of resistance that we try to overcome or to prevent with the new generation of drugs may be EGFR dependent or EGFR independent, and you know the type of molecular alteration. I just put as a remember this summary published 1 year ago regarding the patients who receive first-line osimertinib. One important point is to say that in more than the half of the cases, we don't know. And if we look at the other mechanism of actions, it's approximately in 1/3 some other alteration on the EGFR pathway, with approximately 10% of the patient with the resistance C797S. And in these other cases, it's based on alteration in the downstream pathway or bypassing mechanism. How do we choose how to control the disease? I believe that in the majority of the case, as it is as what we do for the ALK-enriched patients, we would love to have targeted treatments to continue on a targeted therapy those patients who are progressing after osimertinib. Otherwise, the standard of care would be the platinum-based chemotherapy, as we know that the activities of checkpoint inhibitors, at least those that we have in our hand in combination with chemo or given alone, is not really effective. And of course, we would love to have clinical trials activated in this setting. Then the data presented 1 year ago at the AACR showed that we have some of targeted therapies to overcome C797S mutations on development. And the first results with the 2 drugs, the Blue 701 and the Blue 945, have been presented. And probably in the future, this type of treatment will be able to overcome the resistance in maybe 10% of our patients, and maybe in the future to prevent the occurrence of this resistance if they perform like the osimertinib perform compared to the first generation of EGFR TKI. What about the most frequent bypass mechanism, the MET alterations? And as presented, the Chrysalis 2 studies is a study based on the combination of lazertinib and amivantamab, MET inhibitors, and you can see that the best anti-tumor, the best response gained from this treatment was interesting in the setting of patients who were progressing after at least osimertinib and platinum-based chemotherapy, 26%, but it's clearly far to what we expect from a targeted treatment in a setting of oncogene-addicted tumors. And if we look at the duration of response, of course, it's clearly better for those patients who respond compared to those who are not responding. But as you can see on this table, we have lots of trials that are ongoing and looked at combination depending on the mechanism of resistance. And as already said, you can see that in the vast majority of this trial, they keep the blockage of the EGFR pathway by keeping the osimertinib or another EGFR TKI inhibitors, and they add something to control the molecular pathway that has been activated. But in this setting, no major trial was released during the ASCO 2022. Then in conclusion, I would say that we had no major changes for our lung cancer patients, and at least for the clinical practice presented during the ASCO 2022. We have done between a precision medicine approach, what we would like to have in our hand, and one-size-fits-all strategy that is more likely to respond to the expectations of the companies. The role of molecular alterations, to my opinion, will become more and more important in managing the patients with oncogene-addicted tumors, either at the beginning of the treatment to adapt our strategy or where then progress. Of course, it's even more complicated to look at the precision immuno-oncology, giving the multiple components of the tumor microenvironment that is just being explored. And it's why the translational and clinical researchers must be part of our daily practice. And with that, I would like to thank all the people here in Gustave Roussy who are participating in thoracic oncology, and thank you for your attention.
Thank you so much, Fabrice, for your very complete presentation of your interpretation about the abstract presented. We have some time for discuss also with all the colleagues online. I ask to the colleagues that are online to use the chat for some questions to the faculty. We are very conscious that we are in Italy and that we are utilizing English language, but the international guest oblige us to choose English language, but please use the chat also in Italian language, and we will do a translation for, especially for Fabrice, that we are honored that he is with us. I have some questions to my colleagues and also for Fabrice. About the future. In this moment, we are many trials that want to change the first line of the treatment, also target therapies or immunotherapy using different new drugs or different new markers. And in the same time, we have many trials that are ongoing for the management of the resistance and for target therapies and for immunotherapy. In your mind, what is the right way to improve the first line or to search some other drug for the management of the resistance? Please the presenter. So, Gianluca, for your target therapies.
With the questions, it's very different from circumvent the resistance and to overcome resistance. It's tricky for me, really, if we would improve the results of first line treatment. For example, for EGFR, there are a lot of several randomized trials that try to move on from Plaura. There are the strategies to combine osimertinib plus chemotherapy, or as we have seen during the talk, also Mariposa instead that combine a novel third generation lazertinib with amivantamab in order to prevent the resistance, in order that if we can prolong the median progression-free survival, we can at the same time ameliorate the quality of life of patients and translate perhaps, we hope, also to an improving of overall survival. Clearly, this does not mean that we must stop to make research, because there are a lot of bypass pathways, as we have shown during the discussion, the presentation of Professor Barlesi. So if we use, for example, amivantamab in the first line, this fact does not prevent us that the other bypass pathway can be activated. So I think that I would choose both of the two ways: improve the first line results, and again try to improve the results and find novel molecules for the new bypass way that can be activated.
Antonio, your opinion about immunoagents?
So I think that we are in the middle of the storm, considering the immune checkpoint inhibitor management. So in my opinion, of course, the role of chemotherapy is crucial here. And now we cannot treat our patient without chemo. And there we are in a time in which we have a two treatment strategy. So a biomarker agnostic and some biomarker driven. In this kind of time is very difficult from my point of view to target some of specific checkpoint the tumor immunomicroenvironment without a correct biomarker. So this is the show of the TIGIT, the LAG3, and the other. So it's difficult from my point of view targeting an immune checkpoint inhibitor without a biomarker. I know that is very difficult. It is impossible now using the methods that we are using in clinical practice. But we need to improve this. That is a little bit similar at the resistance of the biomarker approach. Mariposa 2 that was discussed by Gianluca is a biomarker agnostic. So using biomarker, the time of resistance is crucial, but it's difficult. And of course, we need to prioritize and improve the first line. Here we know that in about 25-30% of patients progress during the first line in the first 3 or 6 months. And this is the real need for clinical setting. And here the combo, also the immune checkpoint inhibitor alone, are not enough for the clinical setting for elderly people and also for young people with a not very studied biomarker. So I think here we can do enough, but not so much for our patient. And I hope for the future trial evaluating the improving the first line.
Fabrice.
Yeah, I fully agree with what Gianluca and Antonio said. I believe that for me, it's really important when doing the early phases of the development of the drugs to have a large translational studies that help us to understand the group of patients who are likely to respond compared to the other one, and then try to design the phase 3 trial on the basis of these biomarkers. Of course, we know that it's really, really hard regarding immunotherapy, but we did not made, I would say, large efforts in order to try to better characterize of our patients. Because at the beginning we said, okay, it seems to work in the vast majority of the patients. We will just do the millefeuille strategy, which is adding a chemotherapy with one drug and another one. But at the end, we see that we are not able to control the disease in those patients who are not already responding to the immunotherapy. The chemo is protecting the patients from early progression. the checkpoint inhibitors, the PD-1 or PD-L1, are providing the patients with the long-lasting response in 20-25% of the case at best. But in the middle, we have to find how to provide the other 75% of our patients with the benefit of immunotherapy. It could be the combination with other checkpoint inhibitors. It could be the combination with targeted treatments. KRAS inhibitors are, for me, a great example of what we expect to be able to do in the future, but it may be in manipulating other type of strategy. But at the end, we probably have a part of our patient who will never respond to checkpoint inhibitors and will go for cell therapy and etc.
I have another question for you, Fabrice, regarding new target therapies. So my question is if the new inhibitors are different from the historical inhibitors, or the new drivers are different for the previous drivers? It's a provocative question. Sure.
No, I believe that regarding the type of inhibitors that we have, and I believe if we take the example of the EGFR TKI, they are more and more specific, more and more dedicated to the mutated proteins instead of targeting both the mutated and the wild type. Then the safety is clearly better and the activity is prolonged. After that, it's of course difficult to figure what will be the mechanism of resistance when using these new kind of inhibitors. Then we have to treat the patients and characterize the tumors at the time of the progression. But I believe that what is maybe missing in the middle is how we monitor the patients. Then probably circulating DNA will help us in the future to be able to identify as early as possible those patients who are not responding completely regarding the biological disease. Then the circulating DNA, maybe trying to identify as early as possible the mechanism of resistance and add some new treatment there. Of course, the targets are also quite different. If we look at the different types of rearrangements that we have, we know that the partners of the rearrangements will make the disease a little bit different and the activity of the inhibitors also a little bit different. It's true if we look at the RET patients, if we look at the NTRK rearranged patients, etc. At the end, I believe that we probably almost know all of the actionable targets that we have, then we will be able to make some progresses. But if you look at the waterfall plots, even on osimertinib or alectinib, all of the patients are not responding exactly the same, then probably because they are different. Then we have to identify how different they are, why they are different, and then try to better target the different co-molecular alteration. I believe that it will be one of the big parts of the future. At the end, maybe it will be with the combination of chemotherapy or with another better targeted agent.
I have a question for all the faculty. So it's regarding the tolerability of a new treatment, because we are accustomed to historical toxicity or tolerability, and with us also our patients. Now the things are changing, and the new drugs or target therapies or immunoagents introduce a new kind of tolerability. Do you think that these could represent an hypothetical critical point for the next future? Antonio?
I lost your question.
The question is about the tolerability of new drugs or target therapy or immunoagents. So we observe in our ongoing new trials an increase of tolerability. Do you think that this could represent the next future a critical point to change our real life treatment?
So this is, of course, a real issue, also considering the advance on ADC in non-small cell lung cancer that are related to a particular safety profile, and also in the data that was presented during the Asco, you can see that the combination are always characterized by an increasing of toxicity. But in my opinion, we need to understand the long-term toxicity of this kind of patient more than the toxicity related to the 2 or 3 months. And this is not very simple, consider the data that will be reported every time in the results of the abstract of the trial. So in my opinion here, we need to improve our understanding in all clinical trials that consider combination.
Gianluca?
Regarding the targets, it was the topic of my presentation. Amivantamab is a novel agent because it's a V-specific antibody and is well tolerated, even if there is during the first administrations there are a 9% of the reactions during the infusion. So the first one is to split to 2, and then it was really managed with steroids or other drugs. And there are also clinical studies that want to change the administrations of amivantamab from intravenous to subcutaneously. So if this could be a success, I think that amivantamab could be a really drug of the future, because as an excellent result, is already approved for exon 20 insertion, and can be have a broader indication if we look at metexon 14 skipping or EGFR mutations disease. Regarding instead for the KRAS inhibitors, if we look at the data of sotorasib and adagrasib, seems a little bit strange, because sotorasib has a short half-life, only 5 hours, but it is administered only once daily, 960 milligram once daily. Instead, adagrasib has a very long half-life, 25 hours, but it is administered 600 milligram twice a day. So this can explain why adagrasib is a little bit, to say a little bit, toxic than sotorasib. So in fact, the article, the Crystal-1 work was simultaneously published in New England Journal of Medicine. If you look at the details during the discussion, the authors say that they are ongoing in the new schedule, 400 milligram twice a day. But I think that they have to move to another schedule once daily.
Please, the last question, and then our session will end. Also, for your role in this moment at the Gustave C, what is your idea about the next future in the research, and in particular in lung research? Do you see any particular critical point for the research to try to change the standard in the next future? It's a political question, but your role in this moment is also a political role.
No, I understand. I would say our strategy in Gustave C is first to extend our role beyond, I would say, the usual stage 4 management that we all do in our centers. Then it's look more at precision prevention, trying to intercept the disease before the patients at high risk become sick, and trying to put a lot of efforts on early stages, because it's probably there that we will be able to cure really more patients rather than try to prolong patients. And regarding the stage 4, our strategy is to go to ultra personalization of the treatment. We really believe that based on our ability to genotype, or I would say to characterize the tumors more and more deeply, our ability to do a biological avatar for the patients, our ability to set up digital avatar for the patients, we expect to be able, in less than 10 years from now, to generate probably a specific treatment patients by patients and step by step regarding their disease, because we know that generating some antibodies, and especially monoclonal antibodies, could be, I would say, quite easy. Of course, it's more a concept right now than a reality, but I would say it's biologically quite easy to set up specific monoclonal antibodies in order to target and to block the molecular alteration that we will be able to identify in the patients, or by the use of the avatar that will be the most the targets that are with the most highest probability to be involved in the progression of the disease. Then it's what we expect to do, and also to echo what Antonio said, we try also to protect the future of our patients, and we really believe that we are doing a lot of work with artificial intelligence here regarding the analysis of the patients that are treated and how many long-term side effects they present, in order to be able to identify those patients who need to have an adaptation of the treatment during the acute phase of the treatment, in order for them not to have long-term side effects. Then it's our, I would say, globally, it's our strategy here in Gustavo C.
Perfect. Fabrice, thank you so much for your presentation. Thank you for our friendship. Thank you to Gianluca and Antonio for their outstanding presentation. I'm very happy also because more than 150 colleagues are online for our session, so I'm very happy.